everyone. Welcome. If you could take your seats, we're going to start. We're going to start now. I know we're slightly delayed. Princeton parking can be a challenge, but we appreciate you bearing with us through the challenge, and we promise that we'll make it worth it. We won't disappoint. Welcome to the New Jersey Healthcare Quality Institute and the Woodrow Wilson School's Center for Health and Well-Being at Princeton University's symposium entitled Fear of Tears, Finding the Right Balance of Government Oversight, Transparency, and the Free Market for Narrow Health Insurance Networks. I never thought this would be such a hot topic, but here we are today, and you'll probably see people filtering in as they find parking because this was oversubscribed. Today's agenda and the speaker bios as well as other materials are in your registration packets, so we're not going to be giving lengthy introductions. I also wanted to make sure everybody knew that this symposium is open to the public and the press and is being taped. After each segment of the symposium, we will leave some time for audience questions and discussion. It is very gratifying to see so many familiar faces, Quality Institute members, state and federal policymakers, as well as young public policy students. I'm sure Professor Heather Howard might be giving you extra credit for attending. But I want to thank, first of all, Professors Heather Howard and Christina Graff for their wonderful partnership and cooperation with the Quality Institute in sponsoring and formulating today's symposium. I also want to thank and acknowledge the Quality Institute board members who are here. Governor Florio, who's here, as well as, is that your theme song that chimes in? I like it. As well as Heather Howard, former Commissioner of Health, and Christine Stearns, of Partner with Gibbons, and our vice chair on the board, Dr. Suzanne Miller of Fox Chase Cancer Center. The Quality Institute, as many of you know, is an independent, nonpartisan, not-for-profit entity. We are the Regional Health Improvement Collaborative for New Jersey. And what that means is that we have in our membership all of the stakeholders in the healthcare system. We bring those stakeholders together to look at healthcare issues from a systems perspective. So really, what makes the most sense for New Jersey to improve healthcare for the state as a whole and for our citizens as a whole. And our mission is to improve quality, increase transparency, improve accountability, and reduce costs of healthcare in New Jersey. And today we are doing just that by looking at, and by bringing you all together and bringing national experts here, along with local leaders, to look at a very important, timely topic, really the intersection of choice and cost under the Affordable Care Act. While consumers and employers struggle to be able to purchase what is now a mandatory product, and while insurance companies compete in what is now rapidly becoming a more direct-to-consumer world, and while providers struggle to measure and perform successfully on every quality and value-based measurement du jour, how do these elements converge together as we build networks and products in order to meet the promises under the Affordable Care Act of affordability, quality, and access? So today we'll look at that issue, we'll hear from national experts, and then we'll roll up our sleeves with our last New Jersey-based panel to talk about how we can together form a consensus on where our state should go in order to meet that promise. So we're starting our work today and our look today. It's my pleasure to introduce our keynote speaker. He is the managing director at Manatt Health Solutions. But for us former insurance regulators, he's widely known as the insurance commissioner who actually regulated in not one state, but two, both Oregon and then Pennsylvania. It's my pleasure to welcome here to Princeton, Joel Ario. Thank you.
Thank you, Linda. Thank you to the Institute for having me here today. I have to start with a call out to Governor Florio, because it must have been 25 years ago that you hired my friend Jay Angoff to be the Deputy Insurance Commissioner here in New Jersey. We were colleagues in the public interest world at that time, and then Jay went on to be the Insurance Commissioner in Missouri. I went on to be the Insurance Commissioner in a couple of states. Then, as luck would have it, Jay went on to work at HHS, and when the Affordable Care Act passed, he hired me to come in and figure out some of the regulatory issues around these insurance exchanges, and one of the most nettlesome of those issues was what do you do with the network strategy, how much flexibility to allow the insurers, how much to weight different perspectives on consumer protection and so forth. So I love these kind of small world connections. Great to see you here today. So I like to start with a story on these kind of presentations, kind of orient a little bit. So this story is about the Catholic priest who's been out in the hinterlands for a week or two, kind of accomplishing a lot of things, opening some daycare centers, working with through some local problems, and he's kind of feels like he's really done a good job. He's on the plane, he's headed home, ready to relax, glass of wine. But at the last minute, a college kid with a backpack gets on the plane, takes the last seat right next to him, sees the clerical collar, and immediately goes on the attack. I can't believe the Catholic Church, pedophilia, opulent buildings in poor neighborhoods, women can't have any real role in your church, et cetera, et cetera. So the priest is caught listening and kind of being patient. Finally, after like 20 minutes, the kid takes a breath, and the grizzled old priest puts his arm around the kid and says, "My child, after 20 years in the parishes, it is so much worse than you can imagine." I like that story because two aspects of that. One, everything I've ever done is actually messier and more difficult than the worst critics can imagine from the outside. You usually listen to the critics and you say, if you knew everything I knew on the inside, I could double down, triple down on your criticism. So that is the nature of putting together something like the Affordable Care Act and putting together the rules about something like this. But the other side of that is obviously that priest has that kind of perspective on it because he does see that it's all moving somewhere too. And I do believe you'll see that the Affordable Care Act is moving somewhere for us, and it's in a good direction. But this is one of the tough issues that we have to solve. And my role today, first role, is to figure out if I can operate this. There we go, yes. Keep moving through. Is to kind of give us a broad framing of the issues around narrow networks. We're going to hear, I expect, some pretty controversial opinions on different sides of this issue as we go. But I think it's good to put it in a broader continuum and sort of put us all of us in the middle of that continuum somewhere. So there's no question that there's been a lot of negative reaction to some of the products that are out there that are more narrow network type products, or as the insurers prefer to call them, value products that are these surprise bills from people who are in network and all of a sudden find out there's something out of network. There's issues about transparency and not understanding what people bought, just plain access issues. And so you can come to the conclusion that really we ought to go back to the kind of system we had most of the first decade of the 21st century, which was broad PPO coverage for most people. But then you go, well, is that the whole story? Well, not actually, because you got the Kaiser example out there. And one of the things that always helped me orient myself when we were talking about what we should do with networks and how to regulate them would be to say, well, what about Kaiser? Would this work for Kaiser? Because Kaiser is actually a very narrow network product, a tight group of physicians, but they actually deliver very high quality. So I think you don't want to necessarily create a construct that prohibits those kind of narrow networks that are quality focused. And in fact, if you look at the Association of Community Health Plans, that's ACHP there, the plans that tend to score the highest on quality within the Medicare Advantage plan are the narrowest of the networks. They're the provider-based networks. So I like to start with that because I think there's a lot of provider energy around the notion that these narrow networks are really bad. But actually, when providers say they're so bad that we're going to form our own insurance company and get away from the big bad insurance companies that have these narrower networks, then they decide, actually, if we're going to manage this well, we should have a pretty narrow network, and we do want people to really be driven within our network. So there's definitely a case on that side. Of course, there is a case on the other side, as the top headlines say, that if somebody who's a broad-based carrier and advertises themselves as having everybody in the network and then sells something that's not like that, and then people complain, and then they say, well, there was some small print saying you didn't get our premium product up here, you got some different product you should have known, that's not a good kind of situation. But you want to think about this without just thinking that, everybody needs a broad PPO. So now I'm going to go into kind of four issues that I think are really the driving forces of market disruption under the Affordable Care Act. And there certainly has been more than a little bit of disruption in the last 5 years in the marketplace. So again, directly talking about narrow networks, but then also talking about high cost sharing and how that sometimes intersects with the narrow network. Then talking about the balance of federal and state power. We'll come back and talk about what is the NEIC response to the network issues that we see, what is the response to the federal government, and then finally enhanced transparency. The whole system in my mind is about moving towards a more empowered consumer, and I think ultimately the consumer will be the one to decide these issues in the marketplace with some regulatory guardrails on that process. So how do these market disruptors work in the context of narrow networks? First of all, the ACA very clearly does incent carriers to compete on networks. If you take away the main form of competition that carriers had in the individual market, it was never this way in the group market. The group market was took all comers, but in the individual market, the main game was figuring out how to exclude the people who most needed coverage, risk avoidance. Not a good idea from a healthcare perspective, but that's the way the system was incented before. So you took that away, you narrowed the other rating factors that carriers can use. Anybody who kind of really understands insurance markets knew that that was going to produce an incentive for carriers to compete around network strategies, and surely enough it did. And then marketplaces have proven out to be the testing grounds. So you have these narrow networks, you have tiered networks. Here, that's now defined in the ACA and the NEIC model for the first time. And really, you've moved to a continuum approach. It's almost meaningless today to talk about HMO versus a PPO. There are just different kinds of networks within both of those overall structures, and a lot of experimentation, a lot of innovation. So, second disruptor, high cost sharing. Again, the ACA promotes higher cost sharing. A lot of people wringing their hands about it now, and there certainly are huge, huge issues. I don't mean to minimize them for people of lower income around high cost sharing. It just doesn't make sense for somebody who has a very low income to have a very high deductible. So you have to have some protections. And under the ACA program, you kind of combine that because you have a very strong incentive for silver plans to be the main plans of competition in the marketplace. Those are 70% value. It means that consumers, after they paid their premium, on average, they're still going to have to pay 30% of the cost of their health care out of their pocket after that. But to deal with low-income folks, there are also our cost-sharing reduction protections that take that value up over 90%. So that's a kind of balancing within the law. But the point remains that most, gold and platinum plans, the richer plans, there are not a lot of those in the marketplace, and they're not selling when they are in the marketplace. So we are in a world in which silver and bronze is kind of what's there. Some people say, well, let's change that, but you put a dose of reality into it. If Congress does anything, they might add a bronze plan with a 50% actuarial value. They're definitely, a copper plan, they're definitely not going to get rid of the gold, the bronze and silver. So cost sharing like this is here to stay. We're going to have to wrestle with the complications. And then that produces a kind of, an example of where you get some real controversy in the market, because you take a narrow network plan and add high cost sharing to it, and you really do create some barriers, particularly for low income people. And if we go back and think about the last experimentation, it didn't go so well on narrow networks. The HMO period in the 1990s, even though there was tremendous backlash, they didn't have this combination of narrow network and high cost sharing. They had, we're going to give you a narrow network, but then we're going to have very low copays. That's kind of the HMO model. So today, when you combine the two, I have a slide to come back to on this, you start to get some real issues, and you see why there's some of this consumer backlash. So a couple other market disruptors in here that are kind of creating some uncertainty in the market. Next one, federal state balance of authority. The ACA sets a new federal floor, guaranteed issue, essential health benefits, although a lot of that was punted to the states. But there are some basic federal protections, and I think when I was still in the NAIC as an insurance commissioner in Pennsylvania when the law passed, and we recognized that we couldn't solve all the healthcare problems at the state level. We needed a guaranteed issue at the federal level. We needed federal tax subsidies. The states didn't have the money to make this work either. But within that, the law envisioned that states would retain the primary role in the commercial marketplace. Ironically, the people who pushed most for that role were the Republicans, and they ended up then not taking the offer that they got under the law. So what we've seen since the law passed is an erosion of that state power, with states essentially giving back power to the federal government over these issues, and the federal government's never shy about taking on some of those responsibilities. So you've seen a gradual assertion of the federal role. But as we talk about the network issues at the end of the presentation here, the jury's still out on exactly what's going to happen and whether there's room for the states to step up in a state like New Jersey, carve out their own models. But if they don't do that, if they're missing in action, any state that is, the federal government will fill that vacuum. And then there's finally enhanced transparency. Clearly the ACA fundamentally empowers the consumer, just like in any other web-based market. It's a market where the buyer has some real advantages in terms of access to products and understanding the different products and tougher competition. So that is clearly part of the law. People know a lot more about these issues today than they did 5 years ago. The average person, still quite confusing environment, but there are increasingly tools to help people understand the marketplace too. And I strongly believe that ultimately consumers will come through to understand these things again with the help of applications that help them sort through plans, and that the final, you'll see in my last slides, that it'll be the consumer that will decide kind of the fate of narrow networks, just like in the 90s when you have movies where somebody says the word HMO and everybody in the audience boos, that's probably going to translate into a different political response to narrow networks, and it did. And if that ends up being what we have here, if people overplay their hands in this market, that's what will happen here as well. So let's go a little deeper on now kind of what is the ACA approach to networks, how does it regulate networks? The ACA had basically started with a pretty soft standard around narrow networks. It's still a qualitative standard. It was sufficient network to ensure availability of services without unreasonable delay. So that's the NAIC standard. That's a standard in most states. Some states, a significant number of states had imposed viable standards underneath that qualitative standard, but the federal law left it at a qualitative standard. There were some add-ons to protect low-income people. Again, this is commercial marketplace that just didn't serve this population very well. So there are some more specific requirements around essential community providers that many people in this room probably quite familiar with. But again, the law basically set a broad framework and then made the states the primary regulators here. So the initial regulations that we wrote, I'm a state guy. You can probably tell the way I have presented already that I think the states do a better job on this when they take hold of the reins than the federal government. So I used to tell the staff, look at the law, think of the most minimal regulation we can write that gives the states maximum flexibility, and then that's the reg I'd like to see. And if you're done with it, and then think, well, could Joel possibly figure out a way to make it more minimal? If you can, then put that in there too, so that we did build on that some, but the starting point should be a lot of state flexibility, and that's how the first regulations came out. But then there's pushback in the marketplace, as I think there should be on some of the behaviors in the marketplace. And so the NAIC state leaders said, well, we've got to develop a better NAIC model law. That's a process that the insurance commissioners use to try to coordinate things, and that was done in late 2015. Again, CMS has been ramping up its focus on network adequacy, and as we'll see in a minute, the 2017 payment notice sends some real shots across the bow on network standards. So under the broad flexibility in states, basically taking a fairly low-key, let's watch what happens here trend, what happens? Well, as was predictable, the insurers have been quite aggressive in limiting those networks to be price competitive in the marketplace. What I started with Kaiser and the narrow networks being value-based, there's not as much evidence, frankly, in the marketplace that that's what's driving most of the current narrow network strategies. And I think the more people think that all narrow networks are about is price, the more they're likely to react against them, the more they see that actually there's somewhat, and importantly, about quality as well, they'll do better. So I think that issue is going to get joined as we go forward, and it's important to, again, protect, for those kind of quality initiatives. The states are starting to respond. So New York has a law out there that's caught a lot of attention to protect consumers who go to an in-network facility, think they're going to get in-network prices across the board, and then find out that unbeknownst to them there was an anesthesiologist or somebody else who was out of network. We can talk about this later in more detail, but New York has a pretty good protection against that. Now, most states, though, are waiting for the NAIC model, and now I think with that model online, and especially with the 2017 payment notice, you're going to see a lot of activity in 2016. So this issue will heat up this year. It probably belonged a little bit earlier, but it illustrates kind of where you can get in real trouble as a consumer if these issues aren't regulated to some significant degree. So you have the consumer sitting there going, most of the facilities are out of network for me, and then the one that is in network that I could go to has a high deductible, and then maybe even on top of that high deductible, there's going to be out-of-network providers in that facility, and then the insurers may even be using something called reference pricing, where they say for particular things like a knee surgery or something, we have an even lower particular price, and even if you're in network, you don't get the full reimbursement, you only get that lower reimbursement. So you can see where these problems can come from in the marketplace. What has the state response been? The NAIC Model Act, a lot of debate about this, but the NAIC held firm and said, qualitative standard is better than quantitative. It's a big country. It's a lot of different kind of marketplaces. Quantification is not something that we should impose across the board. So you don't have any of those provider to enrollee ratios or time and distance standards in the law. They did for the first time say we're not going to regulate by PPO versus HMO anymore. A lot of states have laws that only HMOs have to have their networks reviewed. Now any form of network plan has to be reviewed for network adequacy, and I think that's how it should be on that issue. Out-of-network protections then, if you're going to have these narrower networks, what happens when you go out? There is a protection in this law along the lines of the New York law, not quite as strong as the New York law, but it basically allows for in-network pricing when you get a surprise bill, an undisclosed out-of-network provider in an in-network facility. And then there's a lot of language in the law and requirements around provider directories, so the transparency issue, empowering the consumer, you obviously have to know what the networks are if you're going to exercise your power as a consumer. And then finally, continuity of care. Some insurers didn't like this being in the model, but it's an important kind of issue of if you're moving around and your doctor's less likely to be in the network you're moving to, then you really start caring about what about the current course of treatment. So there are protections in the law around basically 90 days continuity of care plans. What is the federal response to the current network adequacy? Well, at the same time the NAIC was ramping up and the federal government was saying basically we're deferring to the federal government the federal government was developing new regulations, and I think somewhat of a surprise to some of us, were pretty aggressive in their payment notice. This is like their yearly update to the regulations around the marketplace plans, and they in their law they establish in their payment notice. This is still proposed; it's under review, but most of the time, what's proposed ends up being finalized. They have quantitative standards in their kind of time and county-specific time and distance standards. They take account of the different kind of urban and rural by having the standards be county-based. They do have a deference to state-based exchanges and state-based standards. That still pertains here, but the language is pretty suggestive that the standards, even though they will be in sub-regulatory guidance, if states don't really step up with something on the quantitative side, then likely the federal government will step in. That's where the federal government is on the issue right now. They put some limits on out-of-network, again, not as much as New York did, but they have, out-of-network spending is subject to the out-of-pocket cap, so you can't go over your, 6,000 roughly and 7,000, I guess now, individual and 14,000 family numbers. And then they sort of punted a little bit on exactly what happens with a balanced billing from a doctor. It's always a very nettlesome issue. I've moderated a panel at the AMA, and they were all over that issue in particular and what happens, between insurers and providers in this situation where the consumer is held harmless. I think that's the regulatory answer now, is to try to hold the consumer harmless in some of these disputes. They get what they bargained for with an in-network price if there's an undisclosed out-of-network price, but then that forces the insurer and the provider to deal, and there's a whole set of issues we can get into there in questions. And then they introduced another concept, which may end up being pretty important here, which is standardized plans, because they can then deal with some of these cost-sharing issues directly so that you don't have narrow network with a cost-sharing structure that really is a double whammy for the consumer. So they propose standardized cost-sharing plans. They don't make them mandatory, but they do note that if carriers choose not to use the standardized plans, that they may see they may not get the same space and prominence on the website. So that whole area of standardized plans, I think, would be an interesting one to explore as well. So this is my last slide, and it's about the consumer ultimately. Why do I think the consumer is ultimately going to decide this? First of all, right now, I mean, it didn't even take this 4 or 5 years in the 90s when HMO's price really came out for consumers to pretty vigorously object to them, and it led to patient protection laws that more or less guaranteed PPO kind of coverage. Right now, there's not that same backlash against the narrow networks. And right now, if you look at the evidence, consumers are willing to trade off, a narrow network for a lower price in the front door. But, a lot of people that have watched this market for a long time say, well, there's still huge issues about, consumers having choices between networks and transparency and meaningful access. It's one thing to pay a premium for a narrow plan, and it's another to find out, that some service that you really, really need isn't in the plan and isn't available on a network except at an exorbitant price. So these issues are still sorting themselves out. But I like to underscore the importance of the choice issue. I think this is critical. In the 90s, the paradigm was sort of, this is your HMO. There's no love it or leave it. You just this is your only choice. Today, the model under the exchanges is more that there are these narrow network plans, but there also are broader coverages in most places. I had to moderate a panel with a carrier from another state where they had narrowed their networks, and there weren't any longer any broader network plans. That's a much more dicey situation. So if everybody moves to only narrow networks, I think, and the consumer says they have no choices, that's probably going to be a difficult place, and that's a very difficult regulatory problem, right? To figure out, are you going to make everybody pair up a narrow network with another kind of plan? That's the kind of thing that may end up coming up. But ultimately, I think it's going to be transparency that's a very important aspect of this. And I expect consumers will continue to demand more transparency, not so much because they're going to look through all this complicated data. Most consumers don't want to sort through it all. But if you put all that data out into the public domain, there are many, many entrepreneurs out there today who are developing applications, just like they are in every other field with data, to make it really easy for the consumer. So I think the future is where you go on an app on your phone and say, okay, here's my basic demographic information, and it spits out to you, here's the 3 choices that look best for you based on a complicated algorithm that we've designed, and if you want to check some other ones, that's fine. We're going to get to that kind of world, but it depends on the data being out there publicly. And then I think regulators are going to struggle over this issue of, where's the sweet spot where you have some amount of standardization. Clearly, I don't think anybody wants to get rid of the 4 metal levels, because that does help orient people in the marketplace. Maybe more standardization would help around cost sharing as well, but you also want enough vibrancy to have some innovation, and so maybe we end up with something like there's a star rating system so people can actually understand pretty simply what the different network strategies are. So hopefully I've said some things that provoke a question or two about the framing of these issues, although I've tried to be balanced. Hopefully I was balanced in how I set out the issues. I'll stop and take a question or two. I don't know. We started a little late. I don't know where we are in time.
So you're not from New York, but I really want to thank you on the speed, because you got us back on track.
I do talk like a New Yorker.
So we do have enough time for about 15, 20 minutes of questions. And Joel, I want to just kick us off and ask you a question based on your last comment where you said there's a worry that potentially we might end up with a network of a lot of narrow kind of products. Clearly, a tiered network has the advantage of not being narrow. It's a difference in pricing within a larger network. So maybe you want to comment on that as an option, but also I'm wondering if you might flesh that out a little bit. Are you saying that that's potentially a problem that we need to think about because healthier folks tend to go towards the narrow products and there won't be something for us older or not so healthy folks, and kind of thinking of it from that adverse selection standpoint? Logistically here, we have a couple people with mics in the back if you don't feel like standing up, and we also have some mics up front if you want to stretch your legs. But go ahead, thanks.
So great question, Linda. I have 2 responses. One sort of queuing off the last part of what you said. Yes, it's a narrow, broad network continuum is sort of like the bronze plan to the platinum plan, and we've already seen platinum plans basically, they're not very available in the marketplace, and even though gold plans are required, you're seeing enormous pushback against them, and they're not very available, and they're priced kind of high, which is a little curious because they're not, the way the law works with the single risk pool, you're not supposed to, as an insurer, be able to price up gold based on the kind of people who select gold, but somehow the gold plans are not very attractive to people in the market. They're priced high, and I do think we're in a market where it's kind of settling down at the low end. So I do worry that the same thing happens with networks, that to deal with the affordability issue, kind of settles out towards mostly narrow networks out there. And I do think the more consumers feel like I don't have any choices here, the more likely you are to see the issues constrained. And so I think there are, it's sort of like the drug pricing issue. If some company really is exorbitant in what they price, they kind of get everybody thinking about the issue, and potentially there's some backlash. If companies aren't careful about how they do networks, I'm staying away from the local issues, you can see, very carefully here. But if you get that kind of pushback, I think that there's a lot of, this is a messy, could say even ugly sort of area to sort of work through. And if people aren't very careful on all sides, you don't want to squeeze out good innovation. You also don't want to, narrow people's choices too much. So I do worry that networks could become mostly narrow. And the second part of this is that's particularly true. And this isn't New Jersey's problem in rural areas. It's always been true, right? I mean, invariably when I talk about these competitive markets, I had to kind of always start putting in something about urban and rural, because the people that would come up to me afterwards, you gave a bunch of good examples there about what competitive markets are going to produce for people. We're really interested in that in my state, and it would be a small rural state, and I'd have to say, most of what I talked about is only available in the big metropolitan areas where there are competing delivery systems and you can actually structure some real competition. You're not going to have, you know, 2 hospitals in every rural community, particularly in the western states. So these issues are a lot tougher in a rural environment. Other questions or comments? Maybe people want to get to the panels and mix it up, or
I'll ask one. I'll try and be loud though. As a regulator, and you're looking at plan design and network design going forward, what do you see the effect, if any, of the recently announced mergers and the kind of consolidation within the payer industry nationally? Do you see that exacerbating these trends, or maybe not so much?
That's a great question. I don't think it cuts necessarily in one direction or the other. I think one way that the mergers will affect all of this is that you're going to have, if they go through, you're going to have carriers in multiple markets. You're going to have carriers in the exchange market, the Medicaid market, the Medicare market. That's a lot of what's particularly driving the Humana merger, but to some degree the Anthem-Cigna one as well. So you have people across all these markets, and I think one implication of that I would see is Medicare Advantage, you know, has a relatively regulation-heavy approach to networks. There are time and distance standards, and there's a lot of regulatory oversight of the markets, and so in general, I'm of the school that if you want to figure out what's going to happen with Medicaid managed care, and you want to figure out what's going to happen in the exchanges, watch what's happening in Medicare Advantage. So I think that the mergers would further that kind of, you know, convergence of the big carriers and the regulation of all 3 of those programs that would favor, you know, I think the federal government over state governments as more of the regulator. So those dynamics, I think, would probably be the most important ones driving the process. They probably give the insurers more of a upper hand. This is still debatable, but you know, Peter Lee, who's a pretty good consumer guy, runs Coverage California, he came out and said, I'm in favor of these because I think there's the consolidation on the provider side has tipped the balance in favor too much of the provider, and I, you know, from the perspective of what I'm trying to keep prices down for consumers in California, I want these mergers to go through so that the insurers have a bigger stick. So there's no easy answer to that question, but that, do you agree with that, or what do you think?
I think that you know, you're seeing consolidation on both sides of the provider and payer universe. You know, I think, you know, how many key national players, you know, will we have if you know, the mergers are approved by the national regulators, but you know, maybe we'll have 3 large national carriers, and then you have the Blues plans in each state. You know, again, the consolidation is much heavier, I think, on the payer side, even though we're seeing, you know, consolidation on the hospital side and even in the provider side, the physician side. You know, I just think the consumers get a better deal when there's more competition in the market, and it seems like there's consolidation on both sides. And what does that mean for, you know, prices and competition? So, you know, hard to say. Just interested in your perspective as a regulator and somebody looking at the market from that perspective. Another
reality here would be the bigger these companies are, and the more dominant any carrier is in a particular marketplace, the state has that issue, the more expectation there is for the dominant carrier to have a broader kind of philosophy and more choices and that sort of thing. The more the market is less consolidated, the more there are these Kaiser type things, these provider organizations, and a lot of them started ACOs and, you know, the other provider base. I mean, there are a lot of providers out there who are saying, you know, I don't really like the way the insurance companies are treating me, I'm going to create my own. And they're more sophisticated about it these days than they used to be. So the more you create those sorts of things, though there's going to be more reason to say, you know, narrow network strategies. Well, this is one of my concerns. You wouldn't want to squeeze out that kind of strategy as part of this whole thing. But you might end up with different sort of approaches depending on whether you're dealing with these provider-sponsored organizations or large conglomerates that are not really managing a lot around quality anyway.
Thank you. So I guess I have a comment/question for your insight on now that more folks are selecting the high deductible health plans, we're seeing a rising bad debt expense, particularly at the hospitals, and we're also seeing the federal government reducing the subsidy payments that are going forward. So do you see any trend to recognizing the high deductible bad debt as a federal expense that could be possibly reimbursed back into the provider community?
Well, we know that Hillary Clinton has a proposal on that, sort of a supplemental policy to help with high cost sharing. Yeah, I think particularly when we're talking about lower income people, we have these cost sharing reductions already, so building on that principle, I think that problem is front and center, and it doesn't solve a lot if hospitals have paying consumers, but then they don't get, and the consumers have any benefit from the policy until they paid like a $6,000 premium plus a $6,000 deductible. So that's an issue that is on the table. But I'll come back on, I'm pretty hard-nosed about this one. The affordability issue is a huge challenge for us. I just read one of your Princeton guys, Paul Krugman, on the way in this morning. He was kind of, blasting, and it's interesting. A lot of people are blasting at Bernie in the last few days about, don't mess up what we've accomplished with the Affordable Care Act by running off to the single payer right now. Instead, recognize what we have and build on it. And Krugman said, I know that might sound hard-nosed to somebody, who's got a bronze plan and I have better coverage, but only a fool would say no to a life raft because they want to, they demand a yacht to save them out of from drowning. So I mean, I'm just telling you that way Paul Krugman thinks about it. I don't think anybody would accuse him of being an apologist for the insurance industry. So it's these issues are tough. The high cost sharing is going to be there.
Yeah, subject to communications. I really have to strongly disagree with your characterization of the high deductible problem being for low-income people. I think it's actually not as bad for low-income people. For those, certainly it's not a problem if you're in Medicaid. And it's also not a problem as you pointed out, you're at that 90% that you're getting the subsidy. And what we see on the exchanges, the people who are at 3 and 4 times the poverty rate, they're not joining, right? And they're not joining because of these huge deductibles. It's also a huge problem for people, that aren't in the top 10%, that are, maybe incomes 40 through 80, and they have these huge deductibles. I think there's going to be tremendous backlash with that. I'm not particularly a Hillary supporter, but I have to really give her people a lot of credit for putting this out there, because I think it's kind of been, up to now, it hasn't gotten a political voice. And I think it is going to be, quite an issue.
So I agree with everything you said. I'm just saying, as for people make that case eloquently like you just did, it's still going to be okay. How are you going to pay for it? Kind of is going to be the response. And I wouldn't be real sanguine about the ability for us to get more subsidies into this market. A lot of people think, where we are in America today, we might be fighting to keep the subsidies we have. So I'm just trying to bring realism to that discussion. But I don't disagree that anybody less than $100,000 income who faces $12,000 threshold before they get any benefit, that's a tough place to be. One thing I'll say that's on the optimistic side of that issue is that I think you're starting to see benefit designs, covered California again being an example of this, saying, okay, we'll have a deductible here, the bronze plan, it might be $6,000, but 3 primary care visits before you get to the deductible. And the insurers are even picking up on this. And some of these new plans in some of the big cities are offering, a lot of first dollar. I mean, there's preventive coverage already under the ACA, but it's pretty thin. it doesn't even apply, once you have a condition, the preventive coverage doesn't apply. So it's a pretty thin amount of coverage, but I think you're seeing more experimentation to say, we don't have to have a simple-minded, everything's under the deductible. Let's have the services that are most valuable, let's put them first dollar before the deductible. And you can do a lot more with value-based purchasing. Of course, all this complicates it for the consumer, and how the heck are you supposed to understand all this stuff as a consumer? That's another dynamic here. But I'm definitely not saying you don't have the problem that you're saying. I'm just thinking about where it's going to go. Maybe we should get to the panel. I think that we'll mix it up the same. And these guys all know as much about this as I do, most of them. So we'll just mix it over the panel.
Okay.